Maternal mental health disorders. At the end of this session, you will be able to identify and care for common psychiatric disorders during the perinatal period, explain psychosocial risk factors related to mental health issues during perinatal period, discuss the initial management of mothers with mental health issues. The perinatal period refers to the pregnancy and the first 12 months following childbirth. Psychiatric disorders are common in the first and third trimesters of pregnancy than in the second. Unwanted pregnancies are associated with anxiety and depression in the first trimester, whereas fears about the delivery of fetus are common during the third trimester. Psychiatric disorders in pregnancy are more common in women with a history of psychiatric and medical conditions. Depression is the most common psychiatric disorder associated with pregnancy. Pregnant women may also suffer from anxiety disorders such as panic disorder, obsessive compulsive disorder, and eating disorders. It is rare for women to experience new onset psychosis during pregnancy. However, the relapse rates are high mainly due to discontinuation of medications. Mental disorders in the perinatal period. One of the main reasons for relapse of mental disorders in pregnancy is discontinuation of psychotropic medications with the fear of harming the fetus. The patients who discontinue medications are 5 times more likely to relapse compared to those who continued medication. The common depressive symptoms like sleep, appetite, and energy changes are often difficult to distinguish from the normal experiences of pregnancy. Up to 70% of women report low mood during pregnancy. Depression during pregnancy is associated with an increased rate of premature delivery and adverse perinatal outcomes. However, the prevalence of clinical depression is 13.6 at 32 weeks. Similar to other psychiatric disorders, depressive symptoms peak during the first and third trimesters and improve during the second trimester. The management principles of depression in the pregnancy are outlined in the next slide. Psychoeducation on depression, its significance for motherhood and the baby, and treatment options very important as the mental health literacy of all has a major impact on compliance of patients with the management plan. Women with depressive disorders who are successfully managed on antidepressants may be advised to continue treatment. A referral to the psychiatrist for a management plan to be laid down in the pregnancy record would be ideal as this plan will be available to the healthcare teams at all times, particularly at an emergency. Women with mild to moderate depressive symptoms should be offered education and psychological treatment. However, careful follow-up is required to monitor if the symptoms are getting worse. Selective serotonin reuptake inhibitors or tricyclic antidepressants can be prescribed to women requiring antidepressants. The commonly available SSRIs in the government sector are fluoxetine and sertraline. Paroxetine should not be used during the pregnancy. The absolute risks of harms to the fetus from antidepressants in the pregnancy are low, particularly when the risk-benefit analysis is considered. The common psychiatric conditions in the postpartum period are maternity blues, puerperal psychosis, and postpartum depression. Maternity blues, also known as postpartum blues, is observed among 50 to 85% of women during the postpartum period, and this is regarded as a normal variation of emotional change following childbirth. It is more common among primigravida, and the patients have often observed to have had anxiety and depressive symptoms during the third trimester. They are more likely to have experienced premenstrual tension, fear of labor, and low psychosocial adjustment. Women with maternal blues experience brief episodes of irritability, lability of mood, anxiety, and sleep disturbances. Lability of mood is particularly characteristic in maternity blues, and there may be rapid alterations between feeling high and euphoric to feeling low and tearful. Commonly observed other features are irritability and worrying thoughts about the baby. Although not established, the changes in hormones following delivery have been postulated as the causative factor for maternity blues. As postpartum blues are transient and often have no long-term consequences, active interventions are not required other than support, education, and reassurance. The evidence suggests that 20% of women with maternity blues will develop major depression in the first year following delivery. Therefore, an immediate assessment by the MCH or the psychiatric team is required if the symptoms last for more than 2 weeks. Women with maternal blues experience brief episodes of irritability, lability of mood, anxiety, and sleep disturbances. Lability of mood is particularly characteristic in maternity blues, and there may be rapid alterations between feeling high and euphoric to feeling low and tearful. Commonly observed other features are irritability and worrying thoughts about the baby. Although distressing, the symptoms do not generally affect the mother's day-to-day functions and care for the infant. The blues typically begin 3 to 4 days after delivery, peak on days 4 to 5, and often resolve by the 10th postpartum day. Although not established, the changes in hormones following delivery have been postulated as the causative factor for maternity blues. As postpartum blues are transient and often have no long term consequences, active interventions are not required other than support, education, and reassurance. The evidence suggests that 20% of women with the maternity blues will develop major depression in the first year following delivery. Therefore, an immediate assessment by the MCH or the psychiatric team is required if the symptoms last for more than 2 weeks. Postpartum depression is the most common form of psychiatric disorder observed during the postpartum period, with a prevalence of 10 to 15%. A significant proportion of women who present with postpartum depressive episodes progress to affective illness unrelated to childbirth later on in life. Women with a previous episode of postpartum depression are at a 50% higher risk of recurrence in subsequent pregnancies. The risk of postpartum depression in women with a history of non-puerperal depression is 25 to 30%. For all women, the emergence of depressive symptoms during pregnancy increases the likelihood of postpartum depression. Psychosocial factors significantly increase the risk of PPD. Marital disharmony, inadequate social support, and stressful life events during pregnancy and delivery are the most consistent risk factors for the development of postpartum depression. Despite its high prevalence, the symptoms of PPD are often overlooked by patients, caregivers, and at times healthcare professionals. Therefore, many women report depressive symptoms for many months before coming to services seeking help. The depressive symptoms of PPD usually begin within 3 to 6 months after delivery. Patients with PPD may experience mild, moderate depressive symptoms to more severe depressive disorder with neurodegenerative symptoms, dysfunction, and psychosis. In its most severe form, postpartum depression results in profound dysfunction. The risk to self and baby is considerable when depression is severe, leading to suicide and infanticide. Untreated PPD can have many adverse effects on the mother, husband, baby, and the family. At times, PPD of the mother can result in psychological issues in the child later in life. Despite the above mentioned adverse effects, sociocultural issues, lack of mental health literacy, and fear of adverse effects on the baby through lactation sometimes leads to suboptimal management of PPD. Signs and symptoms of postpartum depression include persistent sadness, lack of energy, lack of enjoyment, irritability, sleep and appetite changes, lack of sexual desire, excessive worry, emotional lability, feelings of guilt, poor concentration and memory, ambivalent or negative feelings toward the infant, worry or concerns about their ability to care for the newborn, anxiety and obsessional thoughts. Education and psychological management can be undertaken for those with mild to moderate depressive symptoms. If the woman is on antidepressants, optimizing the treatment after thorough assessment is very important. Pharmacotherapy, usually with serotonin selective reuptake inhibitors, for those with severe depression, tricyclic antidepressants are also possible agents that can be used in severe depression, although tolerability may be a limiting factor. It is important to highlight that the absolute risk to the baby from antidepressants during lactation is low with SSRIs and tricyclic antidepressants. Severe postpartum depression at times may require inpatient care with administration of electroconvulsive therapy. They should ideally be managed in a mother-baby unit. Apart from the pharmacological management, addressing psychosocial, breastfeeding, and issues related to caring of the baby are important for better outcomes. The main differential diagnoses that should be considered in relation to a woman who is psychotic are delirium, mood disorders such as bipolar affective disorder with mania, depressive or mixed features, depression with psychotic symptoms, and schizophrenic form disorder. The estimated incidence of postpartum psychosis is 1 to 2 per thousand births, which is above the expected rate of psychosis in women of the same age who are not in the postpartum period. Like postpartum depression, puerperal psychosis are common in primiparous women and those who have had a previous major psychiatric disorder, particularly bipolar disorder. The onset of puerperal psychosis is often within 2 to 3 days of delivery, and usually within the first 1 to 2 days with a sudden onset and rapid deterioration. The clinical picture will predominantly be delirium, mood disorders, or schizophreniform disorders. Although common in the past, the delirium rates are decreasing due to reduction of sepsis with antibiotics. The clinical features of these clinical entities are similar to those of the corresponding disorder in the non-puerperal stage. Delusional beliefs often involve the baby. The severity of the illness often impairs the mother's normal functioning, including the ability to take care of the baby. Management principles of postpartum psychosis are outlined in Box 5. The assessment should focus mainly on the risk to the mother and the baby. Inpatient management at times under the Mental Health Act in a mother-baby unit may be required considering the risks and the psychosocial support systems. Observations of the mother and the baby for the risks of suicide, infanticide, child abuse, and neglect is of utmost importance in the management of a woman with postpartum psychosis. The pharmacological treatment is similar to the corresponding illness of the non-puerperal period. However, passage of drugs to the baby through breast milk should be taken account for. In women who are on clozapine, breastfeeding is not advised. At times, electroconvulsive therapy may have to be administered. Women suffering from anxiety disorders in postpartum period typically worry about care or health of the baby. In this period, obsessive compulsive disorders are particularly frightening to the mothers as the obsessions often involve thoughts of harming the baby. Post-traumatic stress disorder may develop in women who have undergone extremely stressful events during childbirth like difficult labor or death of the infant. The anxiety disorders are treated similarly to non-puerperal patients with pharmacological and non-pharmacological methods. There are safe psychotropics that can be used in pregnancy and lactation. The decision to use psychotropics should be made after considering the disease severity and safety. Ideally, the medications of patients with pre-existing mental health issues should be reviewed before conception. Always refer women on psychotropics to psychiatrists so that a management plan is formulated for pregnancy and postpartum period. Sodium valproate should be avoided in women of childbearing age. Specialist opinion should be obtained regarding patients who are on clozapine and lithium carbonate. Breastfeeding should be avoided if the mother is on clozapine or lithium carbonate. Women with a complex or severe mental health problem who are planning a pregnancy should be referred to the psychiatrist for timely preconception advice regarding the care plan, which includes changing medications, optimizing treatment, follow-up, monitoring of mental state, and physical parameters. Screening in the perinatal period is important to identify high-risk women for early interventions. Therefore, it is advisable that all mothers registered with the MOH office should undergo biopsychosocial risk factor screening. The management algorithms for women with mental illnesses and risk factors are given in these slides. In summary, there are common mental health issues that may be identifiable in the primary care setting. All pregnant mothers shall undergo a mental health risk assessment at the booking visit based on psychosocial risk factors. Early identification will allow appropriate care and referral.